You can see just how narrow the patient's ear canal entrance is. I can just about insert the Zollner suction probe, but almost from the offset, I realised that this is not going to be able to be extracted using suction. The wax is too matted, it's too dry, there's loads of skin adhesions. So I've reverted to the forceps, and the entire procedure in the left ear from here on in is performed using crocodile forceps. Because of the narrow entrance, I've used a 5mm fine jaw. I know they look very magnified on the camera, but believe you me, they are micro forceps. These are when you have them in front of you, you can't see the ridged ends of the jaws itself. So it's that minute and small. So just lateral near the entrance. I'm just trying to get. Just trying to prise onto this, and because of the hairs, when I'm pulling it, some of the hairs are coming detached, so it's not the whole plug of wax is not coming in one single piece, unfortunately. So it's just going in and out patiently. You can see the forceps just about fit inside. I should say the teeth. When I was referring to the forceps before, the ridged end, I mean the teeth. So the teeth on these forceps, they are more or less invisible to the naked eye. I thought, let me just try an ear hook to get in and behind this dry plug of skin and wax, but in actual fact, it ended up pushing it further in, so I decided to revert back to the forceps and just bringing it back forwards again laterally. The patient's got a very bendy, twisty ear canal as well, which didn't help, which made it a bit more complex. Loads of hairs, so typically, not always, it's not exclusive, but male patients tend to have more cilia, so hairs at the entrance of the ear canal, and so do elderly patients. It's Oz law, as you get older, where you want hair, i.e. the back of your scalp, there's none to be found, and where you don't want hair, so in your nasal passages and ear, you have plentiful of hairs, so it's sod's law, unfortunately. Some people ask, is it best to trim these hairs? I say no, as long as they're not causing an obstruction whereby you can't visualise the eardrum, let them be. If you trim these hairs, they're going to grow back very quickly anyway, so it's not going to... I can see the logic. People often ask the question, if you trim the hairs, will it help the wax migrate? In actual fact, some of these hairs, where they're aligned and the direction they're pointed at, facilitate the natural migration of dry skin and wax. Obviously, if you have excessive hairs, it can cause it to mat. But if you were to trim these, they grow back quicker than the wax naturally migrates anyway. So it's counterproductive, really. Sometimes during a procedure, if the ear is completely full of hair, and as I said, I can't visualise the eardrum, I use forceps to pluck them. Is it uncomfortable? Well, patients can feel it, but it's no more uncomfortable for women undergoing waxing. So it's very well tolerated. You can see this is the large mass, it shows how hairy it is, how matted it is. So just going back into the ear, lovely healthy eardrum, textbook eardrum actually. And patient's a hearing aid wearer, so they're now able to put the hearing aid back in. So just in the right ear, because of the opening, I decided to see if I can just get the hook in and behind and pull this out. It just sliced through, just dissected through the wax and dead skin, just like a hot knife through butterwood. You can just see now on the right side, the ear canal's far, far narrower. In fact, the ear canal's collapsed. As we age, the cartilage, so the outer third of the ear canal, it can lose its rigidity and it can start to droop. The cartilage weakens, a bit like the tip of our nose. We end up with cartilage as we get older. In some people anyway, that cartilage weakens and it can droop and you get a droopy tip. Similar to the outside part of your ear, obviously gravity as well. There's nothing supporting the outer part of your ear. It's extended and protruding out away from your head. Cartilage can weaken, gravity can pull it down, and in this case the entrance of the ear is completely shut actually, and you'll see as I'm bringing this out, it gets trapped near the entrance. It's almost like a Venus fly trap, the entrance of this ear canal. It doesn't want to let go, it kind of closes upon itself. And quite often, as I was bringing the wax forwards, you see it get trapped at the entrance. So I'm just using a bit of suction here actually. It worked a bit better suction in the right side. I am going to go back to the forceps. You'll see that at the end there's a bit of a dead skin peel. You can just see how shut this ear canal is now. I'm having to prise it open. Slowly but surely we bring this forwards. So the patient has got this dry wax, keratin. Again, a lot of elderly patients, not always, but a lot of elderly patients do get a lot of dry skin. As we age, our skin cells are less able to retain moisture, so the intracellular fluid, and therefore it causes the skin cells to become very dry, and you get loads of keratin buildups. Keratin is a protein. It's typically found in cells that are dying on the surface, epithelial layer, the outermost layer. We have keratin, as I said, on our nails and hairs. And keratin it's hydrophobic, so it has got some useful properties. It's there for a reason. So if you get water in your ears, the keratin can help almost repel the waters. We don't want water in our ears, guys. It's really bad news. Also keratin, it can help deflect and reflect away harmful UV rays from the sun. So just bring this last piece of dry wax outwards. So I'm going to stretch the ear open, insert the endoscope in, stretch it ajar, using the endoscope almost like a doorstop now. Once I've stretched the ear open, we put the endoscope in. And this is the full Zollner suction probe we've got in there, so you can see even with the most narrowest and twistiest ears, we're able to insert not only an endoscope but also a 2mm Zollner suction probe. The skin at the base of the ear canal is very strongly adhered. It's going to go back in with a fine end, but eventually I am going to use forceps to prise this away. If you stay tuned, you'll see that. So I'm just lifting it up enough so I can get the bottom jaw of the forceps underneath this skin. And so when I close the forceps, the top jaw and the bottom jaw are either side of the skin, and the teeth of the forceps can get some purchase and grip. I'm just peeling it off the anterior canal wall also. This is at the base now, and this is on the posterior canal wall. So anterior means to the right, so front part of the ear canal, the base, obviously the bottom part, and posterior means the back. Whenever I do videos, I do want to use technical terms wherever possible, because I do have audiologists, doctors, etc. Watching the videos, but also I want obviously the general public to be able to understand it. So quite often you'll hear me use the medical term and also the lay term as well to describe different parts of the ear. Just using forceps now. Just bringing that out. You can see a long tail of skin. Again, stretching the ear open, using the endoscope as a doorstop, which then enables me to insert the forceps. Just pulling that away from the front part of the ear canal. There's the patient's eardrum. So there's a couple of hairs, a few hairs, we're just going to leave that. They're not loose hairs, they're hairs from the canal wall.